Okay, folks, this is part two. I realize there may be some issues with the screen resolution, and I apologize for that in advance if that continues to happen. I'm not sure exactly why that's happening with Zoom, but you will have access to the slide deck, so you can go ahead and follow along with a higher resolution version of the slides. So apologies if that's a point of frustration. So this next part of the talk, I want to get into some more technical issues around how we use pharmacokinetics to think about some of the challenges we may encounter with medication discontinuation. So remember, pharmacodynamics is what the drug is actually doing at the receptor site to the body, and pharmacokinetics is what the body does to the drug. So how the drug is moved around once it's absorbed, how it's metabolized, and how finally it's eliminated from the body. And some of these basic things that we talked about in the first couple of weeks are going to come back into relevancy here. So ideas such as, so PK refers to pharmacokinetics, and things such as Cmax, which is what is the highest amount of drug that is in the serum. Tmax is how long it takes to get to that point. Concentration minimum is the lowest amount of the drug. There will become a point at which above this Cmin where the drug no longer is effective, so what we call the minimum effective concentration. And then, of course, half-life, which you're familiar with, is another really important predictor of which medications are going to cause problems. So the shorter half-life meds usually are the ones that are more challenging to discontinue. And the whole amount of time plus drug is known as the area under the curve. So that's the amount of exposure one has to the drug. So half-life, again, really, really critical because not all drugs have the same half-life as you know. And the idea of half-life is how long does it take for that drug to drop by 50% in the bloodstream? As we age, that time tends to get longer as it takes longer to metabolize and eliminate the drug. And as you know from drug-drug interactions, a second drug can cause the enzymatic pathway, the cytochrome P450 or UGT pathway to speed up, which will cause the second drug to be kicked out faster, or slow down, which will cause the second drug to stick around longer, maybe leading to more side effects. So there's a bunch of different variables at play here. And just as it takes 5 half-lives for a drug to go from no drug in the body to a steady state, meaning roughly the same amount of drug coming into the body as it is leaving each day, takes 5 half-lives. It takes 5 half-lives for the drug to be eliminated from the body. So this is why those short half-life drugs come out very quickly and often lead to those kind of withdrawal symptoms that we've talked about. And some drugs, by the way, are meant to leave the body every day, such as stimulants. Don't ever tell a patient, well, it takes, months for this drug to build up in your body. That's nonsense. With regards to stimulants, that is. With an antidepressant, it may take 5 weeks for those downstream effects of the antidepressant to take effect. But with a stimulant, you will see the results very quickly, and that drug needs to leave the body every day so that the patient can sleep. So we know that with regards to these ongoing chronic medications, the drugs that are going to be more challenging are the short half-life drugs, your venlafaxines, paroxetine, alprazolam, if we're talking about benzodiazepines. And the meds that are easier to get off of are things like that have long half-life, such as fluoxetine, aripiprazole, clonazepam, because of that longer half-life. And so, again, we're checking in with the patient. Is this medication still necessary or essential? Are there other things we could be doing, like CBTI instead of a med for insomnia? Is the person in therapy and not just taking antidepressants? We want to look for redundancies, and we'll talk about this when we get to some of the cases. And then we're also thinking about, can we swap out a short-acting drug for a long-acting drug? And those are all things that will help guide our thinking about deprescribing. And again, going slow, getting there eventually is more important than rushing and not succeeding in getting there. So again, there's no clear guidance about how long you should be on an antidepressant for. The last guidance that came out from APA is now 15 years old. But typically in practice, what you see is, and what I've told patients many times is, let's get you well, and then let's keep you on that medication for sort of 6 to 12 months. Let's kind of let the glue dry before we take the clamps off, to use a woodworking analogy, right? Let's use that time to get you practicing things that maybe you're learning in therapy or lifestyle changes. Let's think about your support system for when you do come off the medications. And then let's think about what are the likely problems from the medications once they're stopped. So, we've talked about those serotonergic antidepressants often will cause those kind of flu-like symptoms or brain zaps. Meds like paroxetine that have an anticholinergic effect in addition to its serotonergic effect. Sometimes when that anticholinergic effect is stopped suddenly, you get a cholinergic rebound. So whereas you get constipation when you block acetylcholine receptors, when they're suddenly unoccupied, sometimes you get things like diarrhea. And then the noradrenergic antidepressants like bupropion are often a lot more forgiving than the serotonergic ones. And I love this metaphor that I borrowed from a nurse practitioner colleague, really talking about how meds are kind of like a life jacket. They keep you from drowning. They can be helpful for a short period of time, but really what you want to do is learn how to swim. And the best way to learn how to swim is to take lessons. And lessons in this case would be therapy or lifestyle changes that allow the person to continue to feel well even when they're off the medication. So again, looking at the medications that are going to cause us the most problem, typically your venlafaxine, duloxetine, desvenlafaxine, and then paroxetine, as we've talked about. The ones that are much easier to do are like fluoxetine, which has this very long half-life. I mean, you can see the half-life here is at minimum 4 days. So 4 days times 5 is 20 days. So it's going to take 3 weeks roughly at minimum for fluoxetine to leave your body. And bear in mind, there is a active metabolite, norfluoxetine, that lasts even longer. So fluoxetine, you can pretty much just stop it, honestly, and it will just leave the body so slowly that it's almost like it's got a built-in taper. But don't do that with a desvenlafaxine or a duloxetine, that's for sure. Now, what we often find with these meds is that the first part of the discontinuation is relatively inconsequential. So you can cut the medication off and by 50%, they won't report any withdrawal symptoms. But when you start getting smaller and smaller, they do. And the reason for that is due to something called a hyperbolic curve. So a lot of times when we think about medication dosing, we think about this in a linear fashion. We think, oh, well, if I give twice the amount, I'll block, I'll affect twice as many receptors, right? The answer to that is actually no. So check this out. So this is citalopram. Now, of course, citalopram blocks the serotonin transporter. You all know that. But look at this. At 60 milligrams, we're occupying that transporter by about 88%. Pretty good, right? So that's maximum dose of citalopram. It's actually above what the FDA recommends now, but 60 milligrams you see sometimes. So you would think, okay, so if that 60 milligrams equals 88%, if you were to go down to 30 milligrams, which is 50%, shouldn't you have like 44%? No. So look at this. So they don't have 30 milligrams on here, but between 40 milligrams and 20 milligrams, you see, let's just say it's somewhere in between there, you'd see about 83% occupancy. So you go from 88% to 83%. We've only gone down by about 5% by even though we've reduced the dose by 50%. So we actually don't get down to 50 to half of 88%, which should be around 44%, until we get down to about 3 milligrams. Check this out. So between 3.4 and 2.3 milligrams would be where 44% occupancy lands. So that is like many-fold reduction from 60. But the point is you can follow this on this hyperbolic curve. So as the dose goes down, at first we don't see much of a change. That's why it's flat here. And then once we get below um, about 10 milligrams, we see this precipitous drop off in occupancy. So this helps to explain why the first part of your reduction is relatively easy, but the last part is much more difficult. And so if we're going to reduce the drug amount by the proportion of how much it's occupying the receptor, we need to think about reducing by about 10% of current total dose per month. So let's do an example here. If a drug is 20 milligrams and we reduce it by 10%, we're going to go down to 18 milligrams. If we reduce that by 10%, we're going to go down by 1.8 milligrams, which puts us at 16.2 milligrams. If we're going to reduce that by 10%, then we're reducing it by 1.62 milligrams, which puts us at 14.62%. Sorry, 14.6%. So you can see this gradual decrease in dose can take, well, first of all, it can take a long time. Also, it makes dosing this rather tricky because the available pill sizes tend to be in these large increments, right? And so how do we do this? Like there's a couple different ways we can do this. One is that we can use a compounding pharmacy, and I'll talk about that in a moment, for people that are really sensitive to make these micro reductions. The other is that we can do something called a fluoxetine substitution. So this is particularly helpful when you're trying to get somebody off of something like venlafaxine or desvenlafaxine or duloxetine. So what we're going to do is we're going to introduce fluoxetine in addition to the venlafaxine. You can do that. It's fine. And a small dose of fluoxetine, like a starting dose, 20 milligrams, in addition to your venlafaxine. And what we're doing is we're building up this kind of reservoir of the fluoxetine because it has such a long half-life. That way, when we go to stop the venlafaxine in this case, we have that reserve of those fluoxetine molecules that are going to be floating around the bloodstream for a long time, and then allow that, rather than kind of just shutting off the lights quickly, like we would do if we suddenly stop venlafaxine, we're going to allow for this very slow taper, like one of those, dimmer switches, right? So let's take a look at what this looks like. So you're taking 225 of venlafaxine. We're going to add 20 milligrams of fluoxetine. And we're going to do that for, let's say 5 weeks, 5 or 6 weeks. So we're building up that kind of reserve of fluoxetine. And then after they've been taking the fluoxetine along with the venlafaxine for 2 or 3 weeks, we can then start to reduce the venlafaxine. Okay. So we go, these are standard increments, go down from 225 to 150 to 75 to 37 and a half. And it's often somewhere around here that I start running into problems. So interestingly, 225 to 150, no problem. 150 to 75, no problem. Go to 37.5, suddenly they're calling you and saying, I got this weird zingy feeling across my head and I feel like I'm going to get the flu. So we're at some point around here probably going to stop the fluoxetine, and we can then either stop that 37 and a half milligrams of venlafaxine. And what the fluoxetine, that reserve, is going to do is it's going to allow that slow, gradual taper as the fluoxetine gradually leaves the person's body and makes up for the now missing venlafaxine. So this is a substitution taper. The other thing you can do is use an oral solution of the medication. Now, not every antidepressant comes in an oral form, but fluoxetine, citalopram, and escitalopram, and paroxetine will allow you to do this. So using a very small syringe, sometimes even towards the end, you need to use an insulin syringe, but usually like using a 1 milliliter syringe, you can figure out what the dosing is. So in this case, this is fluoxetine 20 milligrams per 5 mLs. So you can do the math and figure out what would be a reasonable reduction of that particular med. If it doesn't come in an oral form, then you can do kind of a hack around this, and you can take something like orange juice to kill the taste. You have the patient out, measure out a set amount, like 100 milliliters, and then you're going to have them dissolve, say, let's say a 10 milligram pill. They're going to crush and dissolve a 10 milligram pill into 100 milliliters of orange juice. So now we have a 1 to 10 solution, right? So if we want them to take 9 milligrams of that drug, we're going to have them take they'll drink 90 mLs of that orange juice plus drug concoction, and they're going to throw out the remaining 10%. And maybe they do that for a week, and then you want them to go down to 8 milligrams. So you would have them do the same thing, throw out 20 mLs, drink the remaining 80 mLs, and so on and so on. Or you can work with a compounding pharmacy and have them do this very slow reduction. There's interestingly now a company that is a deprescribing telehealth company called Outro. I don't have any connection to this other than just having talked to them about their idea. But I think this is really interesting. They hire nurse practitioners to work with people on these very slow tapers, and they work with a compounding pharmacy to create the meds at that very gradual reduction dose. Let's change away from antidepressants to antipsychotics. Typically you're not taking somebody entirely off of an antipsychotic medication because typically schizophrenia, which we're using these antipsychotics for, would be a chronic disease. Now, it's a little bit different when we talk about using dopamine blocking or antipsychotic medications for mood disorders. And so we'll come back to that in a minute. But we might think about reducing an antipsychotic for a patient who had had a manic episode and was in the hospital and now comes out and they're doing much better. Maybe they don't need to be on that dopamine blocking antipsychotic medication. Or similarly, somebody who's had depression, who you've augmented with something like brexpiprazole or aripiprazole, and they're doing better. Can we take them off of it? And I'll talk about data that can guide us on that in a moment. Um, and we want to look for redundancies. Many EHRs will now flag if somebody is on two different antipsychotics. Sometimes it makes sense. Sometimes somebody might be like on 30 milligrams of aripiprazole for their schizophrenia, and they're also on 50 milligrams of quetiapine to help them sleep at night. That's a rational choice. But having somebody on, say, a high potency second generation a dopamine blocking drug like um, paliperidone or risperidone plus haloperidol, which is a first generation high potency dopamine blocking drug, doesn't really make a lot of sense. So we want to look for opportunities to consolidate and simplify. So I think this is a really interesting question, and this is something that has bugged me for a while, really for about the last 10, 12 years, since second generation antipsychotic or dopamine blocking drugs like aripiprazole came into the mood disorder space. So they've always been around as part of treatment of bipolar disorder, particularly mania and sometimes bipolar depression. But in the last dozen years or so, they've really come in as an augmentation strategy with SSRIs, typically for major depression. So aripiprazole, brexpiprazole, quetiapine extended release, a number of different drugs have come into the space. And I've always had a little bit of uneasiness about this because I don't like exposing people to dopamine blocking drugs indefinitely if we can avoid it. In schizophrenia, you often can't avoid it. In mood disorders, you probably can. Now, the question became, well, so the question that was sort of provocative to me was, could we use these as sort of burst treatments? Could we get somebody well so they're on an SSRI and we add something like brexpiprazole and we just do that for a few months. We get them well and then we pull them off. What happens then? Do they remit back into depression um, or sorry, relapse into depression, or do they stay well? So this study really kind of looked at that. So what they did, again, top left survival curve here, is that they waited till everyone was well. And what people had been on is they were on whatever their SSRI or SNRI plus 18 weeks of brexpiprazole. This is Rexulti. Um, and then once they were well, half of them were switched over to a placebo. They didn't know which half they were in. The other group stayed on brexpiprazole. And what they were looking for was their outcome was something called time to relapse. So each group was about the same. So over those 18 weeks of the course of the study, about 20 to 25% of people relapsed. And if they were going to relapse, it happened within a couple of months. So that's useful to know because it tells us clinically, I really got to watch this patient after I take them off of their second generation antipsychotic augmentation. I really got to watch them like a hawk for the first couple of months. And if they're still doing well after a couple of months, I can back off a little bit. Right. So what this tells me is that maybe what we could do is we could do these short-term second generation antipsychotic or dopamine blocking drugs for a few months. So in this case, they did 18 weeks. It's 4 or 5 months. Get them well, and then get them off if they're doing better, and not expose them chronically to the downstream effects of dopamine blockade. Now, if you are taking somebody off of an antipsychotic and they are co-prescribed an anticholinergic medication or an antihistamine medication like a cogentin, benzotropine, or Artane, trihexyphenidyl, don't forget to take those off because they're not going to need them anymore. And we don't want to chronically block acetylcholine receptors, muscarinic acetylcholine receptors in the brain unless we have to. And peripherally, they're not great either because they cause things like urinary retention and constipation. We want to do this slowly, usually, because if you pull off that acetylcholine blockade, you can get this sort of rush of acetylcholine activity, and that can cause things such as diarrhea and other GI concerns. So again, a gradual taper makes sense. Now, what about taking people off of mood stabilizers? This, again, bipolar disorder is a chronic, remitting, relapsing kind of condition. So typically, people need to be on at least some kind of maintenance medication throughout their lives. And you want to do this really carefully. Get consultation if you're not sure what you're doing. But usually, people will have that kind of foundation, like we talked about in the first quarter, of a drug like lithium or valproate or something like that. But sometimes, I've had patients that were on lithium for decades, developed some renal issues, and had to be substituted for something else like valproate. So in that case, you're going to do usually a cross taper. You're going to start up a second medication, get that established, and then start to reduce the first offending medication. What about antidepressants? This is often a place where if somebody with a bipolar condition is not doing well, and when I say not doing well, I mean showing more frequency of symptoms, showing more cycling, more instability of their mood states, and they're on an antidepressant, you might want to think about getting them off of that. And I know that seems counterintuitive because usually when people aren't doing well, we add meds, but this is a place where sometimes less may be more. And this is a very interesting study done a while back looking at sort of day to day. So again, we get one of these relapse curves, right? So looking at the fluoxetine group, okay, so higher in here is worse. So what they're saying here is proportion of patients without relapse. So the longer and lower you go, the better here. So who goes long and low? People on lithium. No surprise. Interestingly, people also on placebo. Interesting. People who did not do as well, folks on fluoxetine. Now, in bipolar 2 depression, a lot of people get put on serotonergic antidepressants, which is probably not a terrible thing. You're not going to flip somebody into mania who has bipolar 2 depression. But what you might end up doing, and this is in monotherapy, so this is not adding it to a mood stabilizer like lithium or valproate. This is in monotherapy. So these people, what they asked people to do was to monitor their mania scores from day to day. So rather than just say, hey, how have you been the last 4 months? They actually had people, I think, keep journals. And so what you see here is that folks that were on fluoxetine monotherapy, this is this top group, are much more jagged. So each of these lines would represent an individual patient. And as you can see, there's a lot more variability in their mood states day to day, week to week, compared to folks who were on lithium, for example, much more stable. A few outliers here, but mostly pretty stable. So the take home for me here is really be careful about antidepressant monotherapy in bipolar 2 patients. Now, what about benzodiazepines? We're in kind of a reckoning period with benzodiazepines. I follow social media in the psych NP space just to kind of see like I keep my ear to the ground and I see people are like, I will never prescribe a benzodiazepine. And I'm like, wow, that's like being in a post-op ward and saying, I will never prescribe an opiate. Like, that seems like kind of an absolutist stance, which I don't think has a lot of evidence behind it. But I am seeing a lot of caution around using benzodiazepines, which I think is appropriate. When I got out of school 20 years ago, we were probably way too permissive with benzodiazepines, and we probably created some problems. But if we think about benzodiazepines more like we might think about prednisone, when we put somebody on prednisone, and I know many of you are primary care folks, so you're very familiar with prednisone, we don't just hand people a bottle of prednisone and just say, yeah, just keep taking this, right? Because we'd cause all sorts of problems. We intentionally deprescribe at the same time we're starting medication, right? So we start that prednisone maybe at a high dose, and then we tell them how to bring that down over the course of time. We should be doing the same thing with benzodiazepines. So instead of saying, here, take this, half milligram of lorazepam twice a day and putting a bunch of refills on it, which basically tells the patient, like, you're going to take this indefinitely. We say, you seem really anxious, and I want to give you something to help you right away while we are waiting for this SSRI to start to work or something like that, or while you're starting CBT for insomnia. And then the expectation is you're going to be on it for a little while, and then you're going to gradually go off of it. And here's how I want you to go off of it. And I would put this in my prescription. Okay. So the number of pills matches the exactly how I expect the person to take it. And I would say, go ahead and use this. Use it on a scheduled basis. Don't wait until you need it. Go ahead and take this. But the expectation is we're going to take you off of this over time. Now, how do we discontinue a benzodiazepine? There's some great resources on this. Probably the most well-known one is known as the Ashton Manual. This comes from the UK. And what they suggest is that, first of all, you do this very slowly. So if you think about 10% of total dose per month, you could be looking at least a year to take somebody off of a benzodiazepine. Let that sink in. Because a lot of times, I think when we think about discontinuing a benzodiazepine, we think about we're going to take them off of it over the course of 2 weeks or something like that. That's probably way too fast for somebody who's been on that medication for months or years. And if we do it super suddenly, like they run out of meds, they can actually have seizures. They can have withdrawal symptoms that look very much like delirium tremens. So they can have the GI distress, they can have headaches, they can have confusion, delirium, hallucinations. They can even have seizures and die. So stopping a benzo suddenly, a high dose benzo that somebody's been on for a while, is a really risky thing to do. So we go slowly. And what Ashton suggests is that we consolidate the total number of benzodiazepines, and sometimes they're on more than one, into a single dose or a single drug of diazepam. And they suggest diazepam because it has a long half-life and it also has active metabolites. So what that's going to make is a much more gradual soft landing. Like just like we talked about how fluoxetine having a long half-life is a lot easier to come off of. Well, diazepam is similar because it has this active metabolite and it lasts for a long time. So, for example, if you're on 2 milligrams of alprazolam, you would convert that to 10. So, half a milligram of alprazolam is equivalent to 10 milligrams of diazepam. So, that would be 40 milligrams of diazepam. And then we make this very slow drop off. And you're going to have to probably treat some of the symptoms that will emerge. So, for example, with insomnia, we might think about using non-benzodiazepine medications for sleep. So something like trazodone or a sedating antidepressant like mirtazapine, or maybe a beta blocker if their anxiety has a particularly kind of somatic experience of it. This is all free. You can find it on benzo.org.uk. A lot more information than is here. Depending on which reference you look at, you may see some variations on this. So in this particular case, So they've said, so this is from Up to Date, so MD Calc. So you'll find some slight variation to these. There is not a, God handed it down on gold tablets from Mount Sinai kind of absolute thing here. What you're going to want to look for is how do you tailor this to your individual patient? So some patients, they might burn through that new drug faster than a different patient. So they might need a higher dose. You're going to look for those withdrawal symptoms. They might be not totally cross tolerant. So diazepam may not work as well as say lorazepam or alprazolam did. So you're going to need to do some tapering here and some tailoring. So see your patients often, check in with them frequently if you need to, in order to make this successful. And remember, any progress in this direction is a good thing. So, sometimes we let the perfect be the enemy of the good. In this case, it's more important that we get there than that we try and go too fast and then fail. And then sometimes, what I found is naturalistically, patients sometimes find their own tools. One of which that's become increasingly common in recent years has been cannabinoids. And so some naturalistic studies have found that if we look at this, that in this study, many people substituted cannabinoids for their sleep medications or their anti-anxiety medications. Is this good? Is this bad? I think again, it's going to depend on the patient. I've had plenty of patients who were on a lot of sleep meds who come in and tell me, you know what, I found this vape that I really like, and I have like 2 hits off of it before I go to sleep, and it puts me right out. And I'm not using any of that Zolpidem or any of the other sleep meds that you had me on. In general, if that person is an adult and they don't have a psychotic disorder or a substance abuse problem, I'm not super worried about it. So again, this is one of the reasons why I'm really kind of excited about rapidly acting antidepressants because, typically what we do is we start people on meds and we continue it until they either stop taking it or the person gets better or they die. Um, Whereas what I'd like to see is maybe in the case of something like ketamine or procedural treatments like TMS, we do a bunch of treatments at the front, we get the person better or psilocybin, and then periodically we treat them. So we treat this more episodically, like we might do with other illness states. Somebody has, an arthritis flare. We might treat that inflammation, get that suppressed down, and then we pull the medication off. We don't keep the person on chronic medication. So I really like this idea of these rapidly acting episodic treatments that don't require exposure to chronic drug. So that I think is really a very much an unexplored area because I think most of the profession for the last couple of decades has really been under this idea that, you treat somebody once, get them well, get them off of it, but if they relapse, sorry, then they'll probably need to be on medications chronically. This idea of more episodic treatments of particularly mood disorders, I don't think has been really well explored. And I would love to see more studies of augmentation strategies being used for short periods of time. So I really applaud the folks that did that Brexpiprazole study. I would love to see that done with other drugs that are used for augmentation, such as lithium, other second generation dopamine blocking drugs. I think that would be great to see. So these are some of the take homes that I hope you'll recall. And in the next and last section, we'll go through some cases to show you how this is actually done in real practice. So thanks for sticking with me, and I'll see you in the next session.